Good evening, everyone. On behalf of Merck India, I am Juhi Gupta from the marketing team, and it's my pleasure to welcome you all to yet another insightful edition of the MedChat series, focused on optimizing outcomes in the METex14 skipping NSCLC. We are privileged to have with us today an esteemed panel of national experts, and it is also an honor to welcome our international faculty, Professor Dr. Greystoke from UK, who brings a wealth of experience in the precision oncology area. So, I would like to thank all our speakers and panelists for being part of this discussion today. We have an exciting agenda ahead covering testing approaches, real world evidences, and practical management strategies in this niche segment. With that, it's my privilege to introduce our chairperson for the evening, Dr. Shama Agrawal, sir. Can we move ahead, please? Sir actually needs no introduction. He's a respectable personal in oncology in India. And also, he brings over 4 decades of experience in this area. He serves as a chairperson of the department at Sir Gangaram Hospital. He's also completed his DM in medical oncology from PGI Chandigarh with top academic honors and multiple silver medals. He is also an internationally trained in bone marrow transplantation from various universities across the world. He's recognized for his experience in bone marrow transplant, immunotherapy, targeted therapy, and CRC management. Doctor also leads the community outreach and awareness initiatives, and he has represented India at prestigious international conferences, including ASCO and SARC Oncology. He is definitely a respectable figure among patients, and he also is compassionate, and his clinical expertise belongs in the lung, breast, liver, and hematological malignancies. With that, it's my privilege to welcome our chairperson, Dr. Shyam Agrawal, sir. Sir, over to you.
So thank you, Dr. Juhi, and thanks to Merck for bringing us together on this platform to discuss a very, unique issue of understanding the MET exon skipping mutation in patients with non-small cell lung cancer as to how it should be diagnosed in terms of DNA sequencing, RNA sequencing, what's the role of liquid biopsies, and what is the background situation where we can find these particular mutations more common than the other subtypes of non-small cell lung cancer. There are several other issues. For example, the PDL1 overexpression, which is so much higher in these patients, co-mutations, and the tumor mutation burden, which is low. So I think this particular subtype of non-small cell lung cancer has become so very important because of the availability of tyrosine kinase inhibitors. And now we do have bispecific antibodies, which can also be used to target this, MET exon 14 skipping mutation in patients with non-small cell lung cancer. And of course, when we are using these newer agents, we have to also understand the quality of life and the adverse events which are associated with this treatment. But to sum it up here, these new drugs are really, really potent, and we all are, seeing positive outcomes. But I think the basic, of course, remains the ability to diagnose through our molecular diagnostics, which has become more and more, validated as we understand the use of these new agents. So today's program is basically we're going to have lectures, we're going to have case discussion. We do have our international speaker who is going to give a review on the subject of MET skipping mutation. And then we have a panel discussion by Dr. Anita Ramesh. So I think the first talk is by Dr. Randeep Singh. He's at the, so I think I'll hand it over to Juhi to introduce Dr. Randeep Singh for his talk. Juhi.
Thank you so much, Sham sir, for setting the context really well. Now, moving to the next session, we have the initial talk by Dr. Randeep Singh. So, sir is a senior consultant and director in medical oncology at Narayana Super Speciality Hospital in Gurugram. So, over to you.
Okay, thank you, Juhi, and thank you, Mark, for having me here. I think my slides and audio is fine, Juhi.
Yes, perfect, sir.
Okay.
Yes, it's fine.
So I think before the professor, we have the talk of professor. My job is to see what is happening in India and to just give just a glimpse of what literature it's available and how we are managing these rare mutations in India and what is the current epidemiology. So starting with the burden, yes, the burden is increasing, and from the last 20 years, there is a rapid increase in the lung cancer. Unfortunately, it has become the fourth common cancer, irrespective of the sex. But when we talk about males and females, in the males, the head and neck cancer is still the number one in India. Whereas in females, there are a couple of cancers which are related to the female genital tract, like breast, cervix, ovary, still being the number topmost. What is also disturbing is that there is a lot of morbidity and disease adjusted life years, and around in a span of 15 years, the lung cancer, which was actually not that much of concern among the cancers in our country, it has become one of the topmost cancers which has associated morbidity. And we all know that mortality because of the advanced diagnosis is also there in our country, which is also a reflection of the global scenario. Coming, when we talk about the advanced lung cancer, then definitely we all know that in today's era, it is an era of personalized therapy. We used to see lung cancer as adeno and squamous, and then we realized, and I realized as a whole community, as a global oncology community, that yes, the adenocarcinoma is heterogeneous. And later on, we also realized that the squamous cancer, which we used to think, there is definitely more and more role, though less relatively when compared to adenocarcinoma. There is a role of NGS testing or at least checking for driver mutations. I think we are all aware, this audience doesn't need this slide, that yes, apart from METex14 skipping, for which we have the drugs tepotinib and capmatinib available, there are other also major mutations, and the most common one in the Southeast Asian continent is EGFR. And the literature from India also does suggest that, and then there are various literatures from the India where do suggest a range of around 30 to 40%, or rather 25 to 35% EGFR mutation positivity among the Indian population. Now, we all do agree that this is more of an US study to see that 80% of the patients in the first line are actually being tested for the biomarker testing. But I think this is more and more every year, it is inching towards 100%, specifically for adenocarcinomas. The squamous cell cancers and the large cell carcinomas are definitely lagging behind for biomarker testing in the first line treatment. Now, there was an era, or there was a time, and when we used to discuss that whether it is more economical to send EGFR ALK ROS, and then if they are negative to go for NGS. But I think the Indian oncologists have also overcome that dilemma now in last 5 years, because earlier we were more focused with the drugs which are like EGFR ALK and ROS. But now, if you leave EGFR ALK ROS, numerically, I mean, proportionally, they do form 50 to 60% of our driver mutation positive population. But then there is an endless list of BRAF, NTRK, MET, RET, where the first line TKIs are important. And I think gradually, we cannot say 100%, but I think 70% of the Indian oncologists have adopted to upfront NGS, and they have started finding that this is more economical. And the TAT, or the turnaround time for the genetic sequencing, which was at one time 21 days, have come down to an average of median of 14 days. And we do hope to achieve 7 to 10 days of median time, and thus matching the global standards. Now, there are two studies, just to have a idea of what is happening in India. This is a study on tissue mutations, and it is good to see that, and this is our experience, and many of us share this experience, that the EGFR cancer, which is a blue bar here, is positive in adenocarcinomas, but we do see in this continent a significant proportion. I mean, a significant means a respectable proportion of squamous cell cancers having EGFR mutations. And then there are other mutations like MET, BRAF, KRAS for matter is very common in squamous cell cancers. And we, on a tissue biopsy, all agree that we cannot differentiate adenosquamous from squamous and adeno. And thus, gradually, there is a role of sending genetic sequencing to as many patients as possible, both for adeno and squamous. Also, we do realize that there is a role of liquid biopsy. There are more and more literatures of which are evolving, with the caveat of cost constraints of sending both tissue and liquid biopsies, and thus trying to cover as much of the mutation landscape, or the mutational, I mean, we can say both the tissue, what is happening and what is shedding in the blood. But short of that, if we have done a tissue and it is inadequate, and the repeat biopsy is in a difficult situation, I think we have reached, or the literature does support us, that once we have a tissue biopsy diagnosis, and then the second biopsy is difficult because of logistics or medical reasons, there is an ample evidence to suggest that we can easily do a liquid biopsy from a standardized impaneled labs which do cover most of the genetic mutations. The one which is there is by one of the colleagues from southern India, and it was a bit surprising to see 9.8% HER2 mutations, whereas, as I already told, that EGFR we have around 25 to 35%. But most of the other mutations and the other literatures where we do a liquid biopsy is matching with the tissue biopsy. I think with this, we do say that this is an unfortunate statement to make, that we are becoming the one of the global contributor for lung cancer. And more and more as this field evolves, there is more and more role of biomarker testing. New mutations such as NRG1 fusions are coming up. The role of MET amplification, especially for the patients who are already progressing in the EGFR mutated lung cancer, is evolving. And apart from with respect to METex14, it definitely has a role in the first line, but it is also one of the resistance mechanisms for the other common EGFR mutated, or sometimes ALK or ROS positive lung cancer patients. There also there is a role of MET to be detected and targeted by monoclonal antibodies, or the combinations of EGFR and MET TKIs. With this, I think thank you for the just stop my slide. I think I will hand it over to the organizers after the brief overview. Over to you, Dr. Juhi.
Thank you so much, Randeep sir, for summarizing and shedding light on the testing scenario in India. Now moving ahead with the next bit of the session, which is by our international faculty. And for that, to introduce our international faculty, I would like to invite our chairperson, Shyam sir.
So it's our proud privilege to have Professor Dr. Alastair Greystoke. He's the honorary medical oncologist at the Newcastle Hospitals in NHS Foundation Trust. He is specializing in lung cancer, fertility in cancer, personalized medicine, and drug development. He's also a lecturer in medical oncology at the Newcastle University. Professor Greystoke joined Newcastle University and the Northern Center for Cancer Care in 2014. After 8 years, he spent at the University of Manchester's Christie NHS Trust. He's involved in the running of Sir Bobby Robson Early Clinical Trials Centre at the Freeman Hospital in Newcastle and has a special interest in the development of new anti-cancer drugs for patients and thoracic malignancies. So we are privileged to have you, sir, with us on this webinar. And your topic is to tell us on the precision in practice, optimizing outcomes in MET exon 14 skipping NSCLC. Over to you, Professor Dr. Alastair Greystoke.
Thank you very much indeed. And can you all hear me okay?
Absolutely.
Perfect. Great. And hopefully my slides will work. So thank you very much for the invitation. I'm very pleased and honored to accept it. I'm sorry I cannot be with you in India, particularly as our junior doctors are on strike today. So we're having to also cover the wards, unfortunately. Let's see if this will move. There we go. So I'm not going to spend a huge amount of time talking about METex biology. We're all aware that in normal life it should get translated, and that if you get mutations in a number of different places, particularly in the introns, that the exon 14 can get spliced out and skipped, and that the exon, that bit of the protein is very important for identifying MET, which is a known oncogene to be ubiquitinated and destroyed, and that by having these mutations that you lead to overexpression of MET, it's an oncogene and it drives and promotes the cancer formation and is a good target for our patients. I'm not going to talk to you about the next slide because we've already just heard how important this is in a number of our patients across tumor types. What I'm going to talk to you about is how does this population do with standard of care treatments? How do they do with MET inhibitors? Which MET inhibitors should we be used and how do we implement these into standard clinical practice? So we do know is that, unfortunately, METex 14 patients do not do well with our standard treatments. So you can see here in one series that overall survival in patients with chemotherapy was only 8 months. And this has been replicated in a number of series where it's between 7, 8, 9 months. So these patients do less well with chemotherapy than we would hope. And we'll talk about the overall survival with MET inhibitors, but you can see in this relatively small series, it was almost triple that at 2 years. We also know that, as in common with many oncogenes, that unfortunately METex 14 does not respond well to standard immunotherapy. Although it actually relatively frequently does have high PD-L1, it's got a low tumor mutational burden. And if you look on the left for that very good review as how patients with oncogene-driven cancers do with various treatments, you can see that the average progression-free survival with single-agent immunotherapy is only on about 2 to 3 months, and this has been replicated in a number of different series. So they don't do well in terms of disease control. If you've seen on the top right, with a median progression-free survival of 2.7 months, and that is replicated in the survival in these patients that they, unfortunately survive only a year, which is significantly less than we would hope for our patients with appropriate TKI treatment. And this is some real-world data that's taken from a number of different data sets, but you can see again that a progression-free survival is higher by using a TKI rather than using immunotherapy, even when you correct, i.e. wait for patient characteristics such as performance status, smoking status, and gender. And equally, if you look at the PFS curves here, in the blue, you will see that there's very few, if no patients who get long-term benefit from immunotherapy, which is what we want. And there are a significant number of patients in the pink who do get long-term benefit with long disease control from appropriate TKI therapy. And this is replicated in these real-world series in survival. So patients who receive tepotinib here have a median real-world overall survival of approaching the 3-year mark. And that is significantly higher than would be seen with those patients who receive either immunotherapy alone on the left, where it's estimated at about 1.5 years, and with chemotherapy and immunotherapy, which would be our sort of standard of care outside of tyrosine kinase inhibitor treatment, where it is just under 2 years. So this has been taken on board in terms of both the European and the American guidance. So you can see the American guidance is to prefer as first-line treatment, and we'll look at the data that backs this up, either tepotinib or capmatinib, and it says you can use crizotinib, which also does have some MET inhibitor characteristics. The ESMO guidelines suggest, again, either tepotinib or capmatinib in the first-line or second-line therapy. I would always prefer to use it in the first-line therapy for reasons that we'll discuss, although I do have a case study of using it successfully in the second-line setting. And then they say if they're not available, then you might want to consider either platinum-based chemotherapy with or without immunotherapy. But I think we all recognize that that is not the optimal treatment. And just to point out, in the UK where I work, capmatinib is not actually funded. We only have tepotinib available. So I'm going to briefly go through the key study, which was a very large study, the VISION study with 2 large cohorts. And that included over 300 patients with METex14 skip lung cancers. And it had some very interesting criteria to it. So it had patients who were enrolled on tissue biopsy. We've just heard about the emerging role of liquid biopsy. And actually in England, most of our patients now do get a liquid biopsy as their first diagnostic test. We can maybe talk about that in the panel discussion. And patients who had both. We'll talk a little bit about the demographics of these patients, but they are older than the standard patient with EGFR or ALK tumor. And this study did actually reflect the real world population with a median age of over 70 and a significant number of Asian patients enrolled in the study, which allows us to examine both efficacy and toxicity. As we'll also look at, it did include both patients in the first and in the second line setting, and also a reasonable number of patients, 18%, who had brain metastasis. So we can start to answer the question as to how effective it is in that population. So I won't take you too much on the design, but it's relatively simple, large phase 2 study that recruited an initial cohort of 150 patients where we have well over 3 years of follow-up. And then there was a confirmatory cohort, cohort C, which was about another 150 odd, where we have about 18 months of cohort. And those could be split into first line and beyond. And you can see here the key demographics. This is an old population at an average age of 70 to 74. And a good gender mix, but most of the patients were performance status 1, and most of the patients had adenocarcinoma histology. So response rates tend to be high at about 60%, and median duration of response, you can see in the tissue cohort, so if you do respond, very good at almost 4 years. Now, it was less in the liquid population, but I suspect that reflects the underlying biology. We all know that patients where you can pick up ctDNA, it often reflects a poorer biology because the tumor is shedding into the circulation. So we see this in a number of studies, and that's reflected in the PFS and overall survival. Being able to detect your oncogene in the blood is a poor adverse prognostic factor. Here you can see the waterfall, and this includes the previously treated patients. So again, a similar response rate with many patients responding, but you will notice that the median duration of response in the second line setting and the PFS is less than in the first line setting. That does suggest that we should use these treatments up front. And looking at patients in brain metastasis, again, response rates are very high, on the order of 50 to 60%. Duration of response, again, less than in the total population, but that would be expected. Patients with brain metastasis do have adverse biology and do worse with all our treatments, including in other oncogene-driven cancers. It's a poor prognostic factor. And here you can just see the forest plot confirming that the response rate tends to be relatively similar for a number of key factors at around about 50 odd %. But duration of response and PFS does vary with the context, whether it's first, second line, whether they're brain metastasis, and whether it is found on tissue or liquid biopsy. And so you can see mean duration of response here, irrespective of performance status and sex and smoking history. So the question then arises that in India, you're lucky that you do have access to both tepotinib and capmatinib. And so which one should you do? We've got the VISION study with tepotinib and the geometry studies with capmatinib, and which one should you be recommending for your patients? And that can be very difficult when you don't have direct comparative studies. So what we often do in this setting where we've got a number of different options is to do a matching and adjusted indirect comparison of the studies. And we sometimes use these for funding decisions as well, for example, in the UK. And what you try to do is try to match up your clinical trial populations for key characteristics such as age, sex, smoking status, and brain metastasis. So there had previously been a published which had suggested that tepotinib might be slightly better than capmatinib, but we have seen more mature data being presented recently, certainly with tepotinib, a much bigger study which I've shown you over 300 patients now, and also later data cuts on the geometry. So I'm going to show you an updated indirect comparison. So in the first line setting where we should be using these patients, what you can see is that it did appear that tepotinib outperformed capmatinib. The only slight problem with this analysis is that because of the matching, the numbers of patients who are eligible that matched up to the tepotinib study was relatively small. So you'll see there's only 28 patients in the capmatinib cohort. But progression-free survival did appear better with tepotinib, and certainly there seemed to be more patients getting that longer-term disease control. No real difference seen with overall survival, but I will comment on the small cohort with capmatinib. In the second line cohort, the numbers were much better and it was much more easy to match them up. And what you can see here is that there was a clear difference in outcome in the second line setting with improvements in progression-free survival and overall survival using tepotinib, both when it was weighted and unweighted when compared to the capmatinib cohort. With a suggested overall survival in the unweighted population and the weighted population of just over a year and a half in the second line setting. So I'm going to spend 5 to 10 minutes, 5 minutes talking about management of TKIs, and then I'm going to show you how we use this in 2 of my patients in clinical practice. So this is a very nice schematic that you can use when you're talking to your patients about potential side effects or when you're using your trainees. But the ones that we really worry about are what's called the MET-associated toxicities. And we find these with all MET targeting agents, including tepotinib, capmatinib, and crizotinib. And that is the low albumin and the edema. And so I'm going to talk to you a little bit more about that. I will also touch in my case about how you will see increased creatinine in some patients. You do see liver function test abnormalities, but these are relatively easy to pick up and manage in my experience. So edema is a class effect of these drugs. We're not quite sure why it happens. It's presumably due to some form of capillary or vascular leak. It tends to affect the legs in particular, but you do also see patients complaining about periorbital edema, and you can also see effusions and ascites. There does seem to be some difference in timing of onset, and with the tepotinib, it does seem to be relatively quick, coming on in the first 6 to 8 weeks in most patients, although it can come on later. It does seem to be a particular problem in older patients, and this is a problem certainly in my patch, because we do see older patients and those that do have other comorbidities. So you can see that the hazard ratio for developing edema on these studies is about a third higher in a 75-year-old than a patient who's 10 years younger. So you do need to take particular care in your older patient population and think about other risk factors, such as if they do have high BMI, if they're not mobile, whether they have cardiac disease, and whether they're on things like diuretics. Do be proactive, looking at physical activity. That's probably the most important thing, elevating limbs and using compression stockings. I haven't actually used reduced salt intake much myself because it's difficult to educate patients, but these are all things that can help, but in particular is looking out for it and looking at appropriate dose modifications. And that monitoring should include measuring body weight every time you see them and limb circumference every time you see them, and looking for potential issues such as with the nails or red areas on their feet, and particularly if they've got other problems such as heart disease or diabetes. And if they do develop edema, stopping the drug, getting it back under control, and then considering restarting at the lower dose. So if you look on the right at treatment adverse events, you can see this does tend to be a relatively well-tolerated drug, but about a third of patients do need a dose reduction. And there are some patients who will need to stop treatment. And in my experience, that is mostly for edema, that patients do not want to carry on. But remember, it is very simple to drop down the dose. So the starting dose is 2 tablets. And if your patient is not tolerating it, you just tell them to stop. You don't even need to get them back and redo the prescription. You just tell them that you can restart on 1 tablet a day. And if they can't do that, unfortunately, there's no further dose reduction and you could stop. So I've got 2 case studies to go through with you just now. One I describe as a very simple case, although hopefully it's also got key learnings for you. And then I'm afraid I do have quite a complicated one, which hopefully will inspire some discussion in the panel. So the first one is just a 67-year-old female, relatively fit, hypertension, was a smoker, and was found to have a right-sided lung cancer following presentation with a neck lump. She proceeded to have, which had nothing to do with the cancer. She proceeded to have a right upper lobectomy, which showed a locally advanced adenocarcinoma. She did have chemotherapy because of the nodal positivity. And at that time, we only did EGFR and ALK testing because it wasn't infecting our surgical managed patients. We've now changed that. Again, we can discuss this in the panel. And she was PD-L1 negative. She presented shortly after this with 6-week increasing shortness of breath to the point where she required admission to hospital and was found had a CT scan that showed left-sided relapse and associated lymphangitis. And we were doing a pilot study within England at that time of sending liquid biopsy, and you can see relatively low levels, just under 0.5%, but showing a MET abnormality. And so I actually started her on tepotinib as an inpatient. Her symptoms improved within a week, where she was able to go home. And she's been ongoing for coming up towards 2 years now, with only very minimal side effects of alopecia and a reduction in albumin not associated with edema. I'm afraid this, and there you can see some very nice scans showing her nice response to treatment, which was rapid and associated with improved symptoms. So that's a relatively simple case, but shows that we can use circulating DNA or liquid biopsy to identify patients, even at low levels of 0.5%. We see these abnormalities in smokers as well as never smokers. I'm sure you will as well, and that you can get rapid responses as with another patient with TKIs. And it's not unreasonable to start this as an inpatient if the patient is hospitalized with cancer-related symptoms. The second one, I'm afraid, is a bit more complicated and will take me a bit more time to go through. So this was a never smoker who just had type 2 diabetes as his comorbidity. And he presented with dry cough, breathlessness, and I think even online you should be able to see that he has an abnormal chest X-ray. And so he got referred through by his GP to a rapid diagnostic pathway. And day 7 after that X-ray, you can see he had a CT scan showing those abnormalities in the right lung, a small pleural effusion, and it was also found to have multiple bone metastasis. So he's a never smoker, which is pretty unusual on my patch. So we want to know if he's got an EGFR mutation or something like that we can treat rather than giving chemotherapy and immunotherapy. So he had a bronchoscopy a couple of weeks later. Unfortunately, this is our National Health Service, and they didn't see any mass. So they just washed out his right upper lobe and found some adenocarcinoma cells, but they couldn't do any molecular testing on them. So he was referred through to oncology, and we said, well, that's not enough in this setting. He needs a repeat biopsy. So he went forward and did have a repeat biopsy. And this time we did get most of his moleculars. It was high PD-L1, 60%. And we were able to get most of the readout on this was a small panel. It wasn't a big NGS panel. It didn't include MET. And it said EGFR was normal, although they also pointed out that the exon 20 insertion analysis failed and they were going to try that again. He started chemotherapy and immunotherapy when we got that result, and unfortunately was admitted to hospital just a week later. And you can see, having been walking several miles a couple of months before, he was now only able to walk 20 meters. So we did a CTPA. He was in atrial fibrillation. He was really quite unwell. And you can see his CT scan had changed really quite dramatically in that 4 weeks whilst we were faffing around trying to get a molecular diagnosis. Actually, on day 86, the EGFR exon 20 analysis came back. And you're going to wonder why I'm talking about this in the MET thing, because it showed a exon 20 insertion. So this was a potential targetable abnormality, although in the NHS at that time, we didn't have any frontline options for it. So I was like, well, that's useful information. We'd also sent a liquid biopsy at presentation, and that hadn't shown anything, but it went to Foundation Medicine, and they sent us an updated report 6 months later, saying that actually we called a MET abnormality as a variant of uncertain significance. We've now reclassified this, and we think that this is a METex14 skip lesion. So I now had 2 abnormalities. I didn't necessarily believe this, so I got my lab to confirm it. So we're now another 2 months down the line, but I've also confirmed that this patient, as well as having an EGFR exon 20 abnormality, also has a MET exon 14 skip abnormality. He actually was doing pretty well in this time, which is good because we were still faffing around trying to get his molecular diagnosis, and you can see his scans showed good response after 6 months of chemotherapy and immunotherapy. And you can see, I've just mapped out the timeline there of the number of samples we were taking in terms of liquid biopsies, repeat biopsies, trying to get a number of tests going, but that it took almost 200 days to get to this patient's molecular analysis, which is clearly not good. What we did find during his chemotherapy and immunotherapy is unfortunately his creatinine was going up. He was on carboplatin, pemetrexed, and pembrolizumab, and it is relatively common to see some renal disturbance, and with a creatinine running around about 150, which is 1.5 times the upper limit of normal. And then you can see at the end a number of CRP tests, a number of creatinine tests, and that's because he was getting recurrently admitted to hospital with fevers, anorexia, and weight loss. We weren't sure what was going on. He had increasing pleural effusion. We were worried this was infected, but we tapped it and there was no sign of infection, and this just showed adenocarcinoma cells. So at that point, whilst he was inpatient again, we stopped his chemotherapy and immunotherapy, and I put him on tepotinib, and you'll see that we saw a really quite rapid rise in his creatinine up to 240. So I stopped the drug and it went down again, and we restarted and went up again. At which point I had to talk to a number of colleagues around the country, and we thought this was likely to be artifactual, and we've been able to carry on his tepotinib at a 50% dose throughout, and you can see his creatinine has stabilized at about 180 with a formal GFR of 31 mils per minute. And his scans look very stable, but he's now been on it for, coming up to 18, 19 months with no further admissions to hospital, no fevers, and actually very little in the way of side effects. He's not had any edema or anything like that. Do be aware that tepotinib can push up your creatinine. Particularly, this patient was actually on metformin for his type 2 diabetes, which can also push up your creatinine. So you just need to be aware of the information there from the SPC, that it may go up and that you may need to do a formal creatinine clearance, which in his case was not as bad as might have been expected from his blood tests. So key learnings from this patient. Not all of my patients are that challenging to get the molecular diagnosis. But you will find numerous abnormalities in MET, and unfortunately, not all of them lead to skipping of exon 14, and sometimes they will get reclassified, as in this patient. It's not necessarily mutually exclusive of other abnormalities. This is well described. And here we were able to use tumor analysis with 2 tumor biopsies and circulating tumor DNA to help work out the best treatment for the patient. Unfortunately, we haven't done well by this guy because we used to give him the wrong upfront treatment option, in my opinion. We gave him chemotherapy and immunotherapy. Yes, it held his disease for 6 months, but it's had a long-term impact on his renal function, and I don't think when the tepotinib stops working, because of that, I don't think he'll be able to get on studies in the future. But at present time, he's going well, and he's got long-term disease stability on second-line tepotinib with control of his symptoms. So hopefully, I hope that's been of interest. I think we still accept that there is an unmet need for patients with this type of disease, that tepotinib is actually a very good treatment option for this patient, particularly in the frontline setting, including in patients with brain metastasis and those in the Asian population. There is an indirect comparison suggesting that tepotinib may be preferable to capmatinib in terms of length of disease control and duration of response. And managing these patients, particularly in terms of the edema with conservative measures and early interruptions and dose reductions, is needed to proactively manage the edema and keep the patients on their treatment appropriately. And with that, I'd like to thank you for your attention. I look forward to the panel discussion.
Thank you so much, Professor, for that insightful discussion session and also sharing your cases. I would like to, we can take one question from the live audience and then we move to the next topic. So there's a question that says, is there any impact of gender in treatment of lung cancer outcome?
So in terms of the lung cancer in general, yes, there is, and that women tend to do better than men in general. When you look at tepotinib, it doesn't appear to be that there is any specific gender differences. I think women do find the edema more challenging in my experience than men, because they're more concerned about their appearance and their ability to wear their shoes and a nice, they'll have accumulated a wardrobe of nice shoes over a lifetime, and they get very upset when they can't wear them if they've got swelling of their feet.
Thank you so much, Professor. So we'll now move ahead with the agenda. Yes, so for our next agenda, we have case study experience by Dr. Shivam Singla. Sir is a consultant in medical oncology at SF Raheja Hospital in Mumbai. So over to you.
Thank you, Juhi, and thank you, Professor Westok and Mark, for this enlightening session. It's always a pleasure to hear. So I'll just share my experience of tepotinib in two of my patients. They are pretty straightforward patients, but different scenarios where this drug has been fairly successful. I hope my screen is visible and my slides are visible and I'm audible. Juhi?
Yes, sir.
Yep.
Yes.
Yes,
Please.
yes, sir.
So this is just my experience with these two drugs. So my case is pretty straightforward. I had this 86-year-old male. He presented to me in January 24. Unfortunately, at this time, I was also treating his son with pancreatic cancer, who was also 68 years of age. So this man presented with productive cough since a month. When he presented to me, his past history revealed that he is also a case of prostatic cancer. And for that, he is on hormone therapy. It was a metastatic hormone therapy. His PSA was normal. When the PSMA PET picked up the lesion in the lung, the oncologist treating urologist oncosurgeon referred the patient to me. When he presented to me, the patient was ECOG performance status 2. I got an MRI brain done, and the biopsy revealed it was an adenocarcinoma of the lung. We have an access to a quick NGS, and at the age of 86, patient didn't want any further treatment with chemotherapy. He was very reluctant, so we got an NGS, and it showed a PD-L1 expression of 36% and a METex14 skipping mutations. He also was diabetic and on metformin. So this was the initial PET scan. You can see that the patient had a high-grade lesion in the upper left lung and the nodal disease. We got a biopsy done. Patient also had interstitial lung disease, which was expected, but he was majorly asymptomatic for the ILD. At this stage, I got an NGS reporting in a matter of 2 weeks, and it suggested METex14 mutation. Now, I had no option. The patient was very reluctant to start on chemotherapy, so I started him on tablet capecitabine initially. The HRCT after 4 months of treatment showed a favorable response, but the patient was reluctant to start on further treatment because he had developed a lot of toxicities. So he got a 3 month break, and then he was started on tepotinib and the PET scan. So I'll just show you what happened. The HRCT on capecitabine showed a significant reduction in the lesion, and it was a fair response to the capecitabine. So this was done in July 24, but he refused to take further treatment because his creatinine had gone up. His blood sugar levels were increased significantly. There was increased amylase and lipase. He was getting 86. His performance status changed from 2 to 3, and I had no choice but to stop the drug. He stopped the drug. After 3 months of break, he came back to me. All the symptoms had reversed, and we did discuss that what could be the other option. By that time, I had got an interest into considering tepotinib for him. I did discuss with him, and the patient started on tepotinib. With tepotinib, the lung lesion improved, and you can see that there was a favorable response by approximately 70% in the tumor reduction. Also, the nodes had reduced significantly. So this was the summary of the patient on tepotinib, that the patient did well and is continuing the drug so far. So what has helped him is that the ECOG performance status has improved, the edema is well managed, and he's fairly happy with the drug on tepotinib. Now coming to case 2, she's a 61-year-old female I had seen. So she had come with cough and since 2 weeks, right-sided chest pain, which was heading to back, a pleural fluid cytology positive for adenocarcinoma, a weight loss, and with ECOG performance status fairly comfortable. MRI brain showed no abnormality in the tumor thrombus in the right and left ventricle with pericardial effusions. By the time I could get this was the initial PET scan. You can clearly see that she had an extensive disease. And I started her on first cycle of chemotherapy because I wanted to give her some benefit from her symptoms. Uh, by the time I could get the mutation analysis, she was already in ICU because of the big thrombus. And I had no choice. As soon as I got the mutation report on day 14, I started her on tepotinib. And as Professor said, this drug leads to symptomatic. In 2 days, her symptoms recovered. And this is a PET scan, which was done after 5 months of treatment. And you can see the liver lesions also completely resolved and the lung lesions also resolved. So she is undergoing treatment with tepotinib. It's been 1.5 years and she's doing well. With this, I would like to hand it back to the organizers for continuation of the session.
Thank you so much, Shivan sir, for sharing your cases. I think it's always insightful to look at a global case with an Indian case as well. So with that, moving ahead with the agenda, the next part of the session includes the panel discussion. And our moderator, I would like to invite Dr. Anita Ramesh ma'am, who's a senior consultant in medical oncology at Apollo Hospital in Chennai. Can we move further? Thank you. So, ma'am has over 22 years of experience in managing adult and pediatric cancer. She holds a DM in medical oncology and has received advanced training in oncology from various parts of the world. Her clinical expertise includes chemotherapy, immunotherapy, targeted therapy, and also stem cell transplantation. She's highly respected academic figure, and she holds more than 50 publications in her name. She's also presented at leading global conferences. Ma'am has a very patient-centric approach, and she combines evidence-based medicine with compassion and clarity in her communication. So with that, it's my privilege to invite ma'am and take the proceedings forward. Ma'am, over to you.
Okay, thank you very much, Ms. Gupta. Okay, and thanks to the entire work to be having me. Yes, can I share my slides? Yeah, I'll just try to share the slides. Okay. Can you see them? I'll put it into slide mode.
Yeah, please, we can see, ma'am.
Yeah, thank you so much. Nice to have all you. Can I invite my panelists? Yes, Professor Greystoke. Hope I pronounced it properly. Okay, yep. Dr. Randeep Singh, Dr. Shivam Sinkla, Dr. A. Preeti. Preeti over there. Yeah, and yes, Dr. A. Preeti and Preeti Agarwal. Preeti A. Okay, and then Dr. Indranil Ghosh, Dr. Deepak Kapaka, and finally we'll invite Dr. Shyam Agarwal to give his expert comments.
Madam, just want to update, Dr. Deepak Kopaka is not here. Dr. Bharat Vaswani is there from Hyderabad.
Dr. Bharat is there from Hyderabad. Okay, instead of Dr. Deepak. That's fine. Okay, welcome, Bharat. Okay, and we go on to the next slide. Okay, today's objective of the panel discussion is to address the unmet challenges in patients detected with the METex14 skipping mutation in non-small cell lung cancer. And also we'd like to know from each other what is the practical insight in the management. And finally, our international speaker will highlight us. So let's start off with Dr. Randeep Singh. What is the incidence of this mutation in your practice? Okay, and before I ask this question, would like to ask you, when you have an advanced non-small cell lung cancer, what are the molecular markers do you do in your practice?
I think almost last 2 years, we have switched to complete NGS in the practice, and my practice is to do NGS both for adeno as well as squamous cancers, and the panels which we send are usually broad panels. And I think if I see this slide, the panel covers all the mutations, and we do look for all the mutations because sooner or later, most of them are in the first line or in the second line, and the resistance mechanisms and the clinical trials in and around the city and country. So keeping all the things in mind, I think almost not, I will say 100%, but 90% do go for a broad-based genetic sequencing. If tissue is not possible, then they go for a liquid biopsy. 5 to 10% of the patients also who are enthusiastic, they go for a comprehensive testing of both tissue and blood together.
Yes, you're right. The incidence range is around 2 to 4%. And Randeep, by chance, what does MET stand for? MET
I think
stands for?
mesenchymal, it is some mesenchymal, I don't know. You're right. I don't
Chymal epithelial transition.
Mesenchymal
Yes,
epithelial
yes.
transition. Yes.
Yes. Thank you, Bharat. Yes.
Hmm.
So sometimes, we will not know the basics. Sometimes I don't know what is red also when we talk so much on red and raw. So just for jokingly, I asked. So that's called the mesenchymal epithelial transition factor. It's exon 14 skipping mutation. It's a driver. And correctly, Dr. Randeep has said 3 to 4% on non-small cell lung cancer do harbor this. And now it has become a target of interest because we do have drugs. Two drugs are there, tepotinib and capmatinib. These are the two drugs which we are very familiar with. Now, next question to Dr. Shivam. What do you think would be your, what is the type of patient population? You showed us two cases. So what do you think, which are the patient population you likely to get this mutation, which may be a little different from the other EGFR mutation?
I think Professor Greystoke in his presentation suggested that it is more common in elderly population and female, irrespective of the smoking status. So this is the two presentation that I have also shown in my case presentation, that my patients, the one was 86-year-old male, he was never smoker, and the other was a female. She presented with aggressive disease. So this is the population that we also see. Now we are seeing more and more MET mutations, and unfortunately we are also getting co-mutations. So I don't know how to interpret
Yes.
the subpopulation analysis on the co-mutation.
Yeah.
But this is a problem, ma'am.
Yeah. So, somewhat you said correctly, these mutation occurs frequently in elderly patients with comorbid, with a history of smoking. And they usually have that sarcomatoid and adenosquamous tumor histology. Whereas when you go for EGFR ALK, they are particularly, rightly you said already, they are never smokers, younger age, longer life expectancy. So some subtle difference which will help us to think, okay, why not there is a METex14 skipping mutation can be really harboring on them. Okay, now coming to Dr. Preeti, okay, in a case of an advanced non-small cell lung cancer, okay, so you have done the testing. Okay, now do you like to do any special NGS test for picking up this mutation, or you just write for NGS and it comes as a panel?
In our center, we have it as a panel, ma'am. The NGS panel is available, the entire set of mutations. So we send it for a solid NGS panel, irrespective of whether the patient has adenocarcinoma or squamous cell carcinoma. We do the complete NGS panel testing for both for lung cancers.
In first line, second line, third line as well. Okay.
Yes, ma'am. Yes, ma'am. Yeah.
Yeah, and whether it's solid or liquid, that's fine. So now let's look into this study, which is tepotinib, once daily, highly selective MET TKI approved on MET exon 16 skipping and non-cell carcinoma. And it's a multi-cohort phase 2. The study is Vision, where we looked into the mutation in the advanced cancer setting, which were wild to EGFR and ALK. And after the central confirmation, tepotinib 500 milligram once daily was given to this patient. And this study looked into objective response, duration of response, PFS, OS, and safety data. Can you see correctly, Dr. A. Preeti has highlighted, we do it for all histopathologies. And okay, so that was the question to you. Are you testing for all squamous cell carcinoma? Yes, as Preeti answered, we are doing a test. Now, coming to the Vision study, Dr. Preeti Agarwal, okay, so again, do you see any difference, like we just discussed a little bit? Do you want to highlight a little more on that, Dr. Preeti Agarwal? She's there, Dr. Preeti? Or if we book to Dr. Indranil? Dr. Indranil.
Yeah, sorry, what
Dr.
was it?
Again, patient characteristics. We discussed a little bit initially. Do you have anything to add on to the patient characteristics where METex skipping?
I have got a around 50-50 male to female ratio, and
Yes.
same for the smoking. So it's a mixed bag. And I also had squamous cell carcinoma in a female non-smoker with METex14 skipping.
Okay, just quickly, one quick question at this point, Indranil, to you. What do you, in these NGS panels which you run, what was the PDL1 status? This particular tumor has a little bit of different PDL1 status. So was there any finding in your cases?
No particular pattern.
You did not find anything. Okay, fine. But if you see the review, the literature, all these MET14 exon are generally associated with high PLD1 inhibitors, and that's a little bit controversial. And these patients, as their survivals are under the immunotherapy, we are not sure whether to use immunotherapy upfront or we have a solid mutation, whether to continue with the mutation as well. So in adenocarcinoma, the percentage was also detected. Now, let's move on to our next panelist, okay, Dr. Bharat. Okay, as per the NCCN guidelines, if you see the molecular testing, we have already discussed. And what is your drug of choice if you get a METex14 skipping mutation?
Actually, sir, my job has been made easier by our distinguished speaker. What is most important is when to use it. Earlier, the better. Because if you see the duration of response in the first, then even you see a PFS close to 20 months, survival 3 years, and it is the difference or the delta difference is nearly 12 months when you use chemotherapy. But what was more important is earlier use, you have a better duration of response, approximately 45 months, which is against 20 months when you use it in the 10 months, I beg your pardon, when you use it in the second line. So for me, whenever I get a report of exon 14 skip and the patient can afford, more importantly, it is always good to put this drug in the as early as possible, because this is where the maximum benefit lies. And I think there is no doubt that with the vision study and the previous study, more so in the vision study, that it outscores chemotherapy heads on. So earlier the better for me.
Yes. So when you have such type of mutation, it's a very important mutation. And all up to now, whatever our panelist has discussed, we all discussed this with the adenocarcinomas, large cell, any subtypes, squamous, METex14 skipping mutation is an integral part along with the PDL1 for testing. And yes, like rightly Bharat said, we have to make it earlier. Now coming back to, we'll go back, Bharat, from you. Which MET alteration you look for in your clinical practice?
Probably the first.
Muted. Yes,
the first and the fourth, I think. The fourth is basically not a primary mutation we look for. What we call as that G7, G8. It is not that. It is probably amplification is more of a secondary or a resistant mechanism that you get. But the most important as a primary driver mutation, I look for it, METex14. Definitely, I look for amplification, but in our experience, more commonly it is with EGFR, or it comes as a secondary mutation post osimertinib. But definitely the most important drive when you look for as a treatment point of view, you look for mostly the first thing, that is exon 14, which is a driver mutation, and an amplification probably, which is a secondary mechanism of resistance, and probably these are the two where used. Regarding fusions, not sure, very less common, 2 to 4%, I think so, of all the thing and mutation. So more of the time 1 and 4.
Yeah, thank you. I would like to have comment from Professor Greystoke. Okay, sir, which is the one which you'll be looking at? Splicing exon 14 or amplification? Or what about fusion? What is your idea about it?
Yeah, so the common ones that we see in practice are the splicing mutations, and we do see amplifications in without mutations, but that tends to be associated with a poor prognosis, and we don't have any treatment for that yet outside of trials. We do rarely see activating mutations in even rarer fusions. We can't treat those outside of trials, but we do have appropriate clinical trials where we'll put those patients forward towards.
Yes, thank you very much for the comment. And now we are clear that how do we go about and the NGS test involves. Okay, now tepotinib is the drug which is given once daily. It's a highly selective MET-TKI skipping mutation. And that was the phase 2 vision study where both in liquid biopsy as well as tissue, which is already highlighted by our panelist, and is the only clinical trial for MET-TKI or a prospective enrollment of patients on the basis of liquid biopsy. Quickly coming to Dr. Indranil Ghosh, what is your preference? You do both or do both? We understand in lung cancer, we always use this first tissue as an issue. But then if nothing is an issue, what is your preference? Dr. Indranil.
Yeah. Preferably, I try to send a liquid biopsy upfront. And by the time we get a diagnosis of adenocarcinoma or squamous in certain cases, I send the liquid biopsy, and once the tissue is ready, then I send it for a smaller lung panel.
Okay, so as such, liquid biopsy, Dr. Indranil, upfront at diagnostic, do you think it's an approved one? Or yeah, you are right. You have done it with the tissue. Without the tissue, how authentic is a liquid biopsy upfront? I know it's in few indications you can use, but I'm looking.
Yeah, if the liquid biopsy can give me the driver, then it's fine. Then I am fine.
But is it recommended to do without tissue biopsy upfront? First line, I don't little agree, but second, third line, I agree with you. Send the sample. What about first line?
See, 3 approaches are there. If you go by the guidelines, you can take either of the 3 approach. You can go for 2 together, or you can go for a sequential tissue followed by, if negative, liquid, or liquid, then if negative, tissue. So I have seen that liquid biopsy can be reported within 10 days. That really helps in starting the patient on treatment. And tissue biopsy, by the time you will do the IHC and PDL1, then you send it for a NGS, it will take 3 weeks.
Okay, the third question is again for you. Do you use both, or you said liquid biopsy is you have some points about it. What about using both? Because if you the study, it use tissue and or liquid. So the last question for you.
Yeah, as I said, I prefer a comprehensive liquid upfront, and I send the tissue usually for a smaller lung-based panel. If the patient is happy to do both broad-based panel, then I can do. Otherwise, the 12-gene panel on the tissue, and send the liquid biopsy even before that.
Yeah. Okay. Thank you, Dr. Indranil. Okay, coming back to Preeti Agarwal is there, or Dr. A. Preeti can take the question. What are your recommendations for managing this patient with METex14 skipping alterations? Dr. Preeti, please.
Yes, ma'am. I'm sorry.
Yes, ma'am. So,
Dr. Preeti Agarwal, please.
Yes, ma'am. Yes. So, yes, I'm here.
Yes, please. Thank you.
So, in MET-exon-14 skipping mutation, we usually start with targeted therapy, either TEPMETCO or capmatinib. But my preference is TEPMETCO.
Yes. Okay. Why do you say?
So, ma'am, I have my personal experience with tepotinib. It has good response, and it also causes peripheral edema, but capmatinib causes significant peripheral edema and fatigue. Okay. So I feel TEPMETCO has comparatively less, although we don't have data to say that, but my personal experience is better with TEPMETCO.
Okay, you're right, Dr. Preeti Agarwal. So similarly, what we discussed, elderly individual, breathless, PET showing a lung mass, stage 4 with multiple liver and bone mets, reasonably moderate performance status, adenocarcinoma. Preeti, also Dr. Preeti Agarwal, I just look at this. We have a MET-exon-14 skipping mutation detector. I've also mentioned that these patients have a high PDL1, unlike any other tumor. I asked it earlier also. Again, we would like to hear from you. What will you do with PDL1 80% here? You are right. You want to start the drug, this targeted drug. What would you do for this? PDL1 is 80% in this particular patient, doctor.
Yes, ma'am. Even the PDL1 is more than even 80%. It is more than 50%. I would choose anti-MET inhibitor. I will choose MET inhibitor rather than immunotherapy, because we know even in high PDL1 and when there is a target mutation present, the target mutation works better. Immunotherapy does not work as well.
Why not combination?
No, I don't think there is data to say that. There is combination of targeted therapy plus immunotherapy. I would choose single agent MET inhibitor.
Yes, at this time, I would also like our international speaker's opinion, Professor Dr. Greystoke, your opinion on this PDL180. And we know that it is a very potent METex14 skipping. So what do you do with the PDL80%?
Yeah, so certainly with performance status 2, I would go with tepotinib. Well, even with better performance status, but definitely performance status 2, I would be going with tepotinib as a frontline setting. As I said earlier, we don't have access to capmatinib. And then on failure, I would then be looking at chemotherapy and immunotherapy. Even with the high PDL1, the 80%, I would be very reluctant to use a single agent immunotherapy in this patient setting. I don't think they do well. So that would be my preferred regimen, tepotinib, and then on tepotinib failure, chemotherapy, immunotherapy combination.
Okay, chemo and immuno. Now, if you had started with chemotherapy, the question to you before your NGS, what would be your next step? So you gave one cycle, it took 21 days for the report to come. Do you change? Do you add? Do you add the MET inhibitor or you continue the same? Patient after one cycle is doing good. Professor Greystoke, sir, is the question for you.
Sorry, I didn't realize. Yeah, no, I think if they've already started chemotherapy and you've got it, I think it's a difficult one, this one. I would tend to carry on, but have a low threshold for changing. Because the problem is if you change to a MET inhibitor at that point, trying to get the patient back to chemotherapy when they fail can be very challenging. The argument against is that first line, second line data. So I'm not sure there's an easy answer to that one. That's probably why I was staying on silent. But I think in my practice, if a patient is already established on chemotherapy, doing okay, I would probably carry on as long as they're tolerating and it's working, but an early threshold to switch.
Yes. So we also had a patient like this. We started with chemotherapy and then the report came as a MET inhibitor. MET exon skipping was positive. But then what we did, we added it to the chemotherapy, continued up to 4th cycle, did a scan, had stable, a partial remission, and then we stopped the chemo and continued with the inhibitor.
Yeah, I wouldn't be allowed to do that in England, unfortunately. And as you saw in my case, actually, so in my case, we did get it back and he was already doing okay on chemo IO. So I did carry on for another 2-3 months. So at least I said there what I did actually do in that case. But I think it's hard to continue.
Yeah. Okay. Thank you. Okay. Coming back to Dr. Preeti, despite of the high PDL1, as already Dr. Preeti Agarwal told, immunotherapy provides a limited benefit in OS as PFS outcomes on these patients. With the MET inhibitors, you expect up to 15 months. It can go up to even median OS up to 30 months. Dr. Preeti, I want to know from you, what is your experience with this drug?
I have yes, ma'am. Yeah, so I have used this drug in 2 of my patients, tepotinib, and one of them had high PDL1 expression. But we had not started him on immunotherapy initially. So we put him on tepotinib, and he has been doing well till now. And the recent scan has also shown up to be a stable disease. The other patient also had a PDL1 expression, and but we had started him on immunotherapy initially because we didn't get the NGS reports initially. So we had started him on immunotherapy, but there was not much of a response as such in that patient. Later on, after we got the NGS reports, we had changed him to tepotinib, and he has shown a good response with tepotinib, and he has been doing well as well. And this definitely shows that with the PDL1 expression as well, the driver mutation definitely plays a major role, and it has an upper hand when compared to the immunotherapy.
Yeah. So again, rightly, all our panelists said, as well as Preeti, we do have real world data supporting this, showing the superior high efficacy of the MET inhibitors. And if you see in first line progression free, second line progression free, it has a significant P value, which tells us, yes, it is the drug of choice. Coming to Dr. Shivam. So what do you think the guidelines say, NCCN guidelines and S4 guidelines during use of these drugs? See, both the drugs are approved. Which one will you use and what is the guidelines of Shivam?
So, ma'am, guidelines give opportunity to use both the drugs, but we know that the cross-trial comparison is more in favor of tepotinib, and we tend to go towards that. The median PFS with tepotinib is higher as compared to the comparator arm when you cross-trial comparison them. So, the guidelines allow both, but we tend to go towards tepotinib in our clinical practice.
Yes, even the ESMO as well as the NCCN guidelines both advise the use of first line, second line of the tepotinib. That's the first drug, and the other drug as well to be used. Okay. Coming back to Randeep, we have heard our panelists telling few subtle differences, but what are the key parameters will you be looking into, doctor, which in choosing which MET inhibitor you are going to take forward?
I think it is very difficult. Professor has already said that there is a match pair analysis, but he himself admitted that that is not the right science to do it. It also depends upon your comfort level with the drug. And whenever I have used capmatinib, I think I share the same thought process that somehow I don't know, the patients who go on capmatinib, their edema is actually difficult to manage. That is somehow, it is actually, of course, it is a class effect, we all know. But I will say on an average, it's 25% more difficult to manage edemas, effusions with capmatinib compared to tepotinib. And then otherwise, if the data does suggest that you can use both the drugs, but most of us, I think, we share that same common thought in this group. So this is a bit of biased group, I will say that. But yes, both of us are comfortable with tepotinib. That's why we are here. And we've all had some bad experiences with capmatinib, and that's why there has been a more of slight tilt towards tepotinib. That is all I can say.
Yes, correct. Yes. But if you see the guidelines, both has equal efficacy and they're approved in first line, second line. And this is some of the chart, though this is across the studies comparison showing a better median OS, better duration of response rate, better median progression free response rate, both when you use it as a first line as well as use it in a second line. Coming to you, back to you, doctor. Okay, Dr. Randeep. Okay, how important is the intracranial efficacy of the METex14 skipping alteration? Okay.
I think it is important, and I think we have, once your numbers start increasing in the practice, you do realize that yes, the brain metastasis is not as big a problem as EGFR ALK mutations, but yes, it is slightly more than a driver mutation negative population. And the efficacy wise, it is a very, I mean, you can't call tepotinib equivalent to lorlatinib or alectinib. I mean, the efficacy is there, but whenever I have treated, there are 2 or 3 patients in the practice, but they did require the support of a radiation oncologist. And in my experience, I'm not very satisfied with the response of intracranial activity with the MET inhibitors as such. And but in someone who has asymptomatic, I can still avoid as a practice, but someone who has a heavy load or they have multiple mutations, I would tend to take support of radiotherapy and then put them on tepotinib.
So this drug tepotinib did show a promising intracranial activity with patients. This is not used for a prophylactic with therapeutic whenever a detected target lesion, and the responses have been partial remission. They have 88% control and response rate was 66. The duration was not yet evaluated, but then these drugs do penetrate the blood-brain barrier. Coming to Shivam, what is your view on the safety of the MET TKIs?
Dr. Anita, can I ask the professor, and can you put the slide,
yes,
the back slide, and if
that same, okay,
this one, does he in his practice this response and these parameters are reflected, professor, of 67-70% response rate and intracranial PFS of around 20-22 months?
Yeah, so I think the problem whenever you look at brain metastasis on clinical trials is you're selecting your population even more for brain metastasis than the rest of the population. So it doesn't reflect the real world brain metastasis population. You know, you definitely do see responses. You see symptomatic responses in patients with brain metastasis. You see radiological responses. But I do agree with you. I would be quicker to reach for the SRS maybe when they're in response to look at consolidation, or certainly at the first sign of progression, and I might maybe with one of the EGFR ALK inhibitors, because I think you do often need a little bit of consolidation to try and keep their brain under control, particularly when they're presenting with symptomatic brain disease.
Yes. Okay. Thank you. So, an use of radiation, particularly the stereotactic radiation, would help. Now, coming to Dr. Shivam, what is your view on safety of the MET TKIs?
Ma'am, I think there are fairly safe drugs. We've had certain experiences with edema, but that is manageable.
Anything else than edema you want to say, because other panelists already highlighted edema?
Yeah, the creatinine going up. I think Professor has clearly said that the creatinine going up, the protein loss, all the MET inhibitors, the skin changes, the skin rash. These are the common side effects we face with MET inhibitors.
Yes, hypoalbuminemia, fatigue, ALT, creatinine increase, nausea, and edema differentiates this, and the safety results have been reported with tepotinib and capmatinib in patients. And these are not comparable study, neither there's a head-to-head comparison, but then we are more used to tepotinib and we are familiar with the side effects, and I think patients have a good quality of life. Okay, coming to Dr. A. Preeti, how do you prevent the edema?
Yes, ma'am. So basically, the general measures like limb elevation and compressive bandages can be used, and proper exercise. All of them can be used to prevent the edema. And if sometimes I have used diuretics as well in my patients to avoid very severe effects of further effects of edema, and patients have tolerated quite well, and it's quite manageable. And proper monitoring is also required. I have not encountered a situation where I would have to reduce the dose as such as of now, but definitely with the current dose itself, the edema which appears has been quite manageable, and in my patients.
Yeah, mainly we may not go up to the dose reduction, but then when it is grade 4, yes, we need to do permanent discontinuation when it is grade 4 and 3, and dose reduction does not affect the efficacy. That's what it is. But then we should be orient the patient upfront, effective communication and management. Coming to Preeti Agarwal, what in your view is the dosing convenience of the MET TKIs? Dr. Preeti Agarwal. Is Preeti there, or we move to Indranil? Dr. Preeti. Okay, Dr. Indranil, you can take this question.
Yeah, again, TAPMETCO, we are very much comfortable because only one tablet strength is there. So from 2 tab, you go to 1 tab. So it's easy to manage.
Easy to. So 225 milligram is what is your last dose, and after that you discontinue. Whereas in capmatinib, dose reduction schedule, if you go down, you can first reduction, second reduction, and you can come down to a little lower dose. And anywhere you get a grade 4 toxicity, permanently discontinue. So coming back to Dr. Bharat, you would like to have the take-home message before we sign out today.
Actually,
Dr. Bharat, please.
Again, what we say is, with the advent of targeted therapy, and more specifically, what we know is there are the drugs which are better, more effective than chemotherapy. So whenever there is a chance to use this drug, I think every one of us should use this drug. It is a safe drug, because I don't think so, except for edema. What Randeep was asking, increase in LFT rare. At least I have not seen that, but something which is known. That is why we have to monitor. Added advantage, that somewhat better efficacy in brain mets, and more so when we were discussing sarcomatoid type or adenosquamous, those are bad subsets of disease. So if you can get a drug which gives you a survival of nearly 2.5 years, nearly 12 months better than when you don't use the drugs with chemo, I think so it is heads on. When you see RET also, these are few drugs where these drugs have improved our survival, and that is what we want, with the equally maintained quality of life. Capma, I had a bad experience. TPO2 patient, thankfully till now it is a good experience. So a win for everyone, madam. probably
Correct.
that is
Yes. Yeah. I also have a patient with tepotinib, and they are all doing well. Good, convenient dosing, good tolerability. Yes, it has penetration into the brain. Only MET inhibitor, single daily dosing, less of side effect, good benefit, and it's a recommended drug in NCCN and asthma. With this, I will stop. Thanks to all the panelists. We had an excellent discussion, and over to the our organizers, and we leave it to, I think, Sham Agarwal to give us the final comments, and Professor Dr. A. Greystock, please. Thank you.
And also our expert panelists for a truly engaging and thought-provoking discussion. I'm sure the audience has gained several valuable takeaways from the session. I would now like to invite our chairperson, Shyam sir, to conclude the session for today.
Yeah,
Shyam
so,
sir, over to you.
right. So, first of all, thank you to our international speaker who shared his thoughts and the cases on the use of tepotinib and the kind of complications we see when we are treating patients with tepotinib. So I think the most important thing is the ability of the lab to pick up the MET exon 14 skipping mutation. So the oncologist needs to be in touch with the molecular biology lab and the person who's doing the testing reporting, so as to include the results for MET exon skipping, preferably the DNA, RNA should be tested. And if there is a high index of suspicion, as was being discussed in the panel, if your tissue is negative, I think a liquid biopsy can also pick up some of these mutations. So I think getting the test positive for the MET exon skipping is critical before a decision is taken. So I think, as was said, patients who have sarcomatoid carcinoma or adenosquamous, so there the index of suspicion should be high, particularly in elderly individuals and with adenocarcinoma. Although smokers and squamous cell also can get the MET exon skipping mutation. So, I think I can narrate a story of a 85 years old with severe pain in the upper chest, invasion of the lung tumor into the bone, etc. And she was extremely frail, and she was not even fit for radiation, could barely walk, and we was waiting for the reports to come in, and we gave her small doses of chemo. But then we got the report of MET exon skipping 14 mutation, and we started her on tepotinib. And to our surprise, a patient who was supposed to go on radiation within 48 hours started showing improvement in pain. So the symptomatic improvement, I think, as was shown earlier by Professor Greystoke, it can be as early as a week or even 10 days. So we've seen such a long duration of responses. We have patients going on beyond 2 years on tepotinib. So I think it is one of the preferred drugs for this skipping mutation. Yes, side effects is an issue. And I think a large number of patients from 50 milligrams do tend to come down to 225. But I think there's ample data to say that the efficacy is not deterred by reduction in the dosing. So I think we are also looking at some high creatinine, which, again, you have to look at the dose if the creatinine goes up. Even serum lipase and serum amylase also needs to be monitored alongside albumin. But I think by and large, whatever experience we have had with this drug in this scenario is really fruitful and positive. And I think we are, we sort of, although the only issue is, of course, the cost here, which I'm sure Merck should look into, because although the number of patients are small, but then whosoever can derive the benefit from this drug should be in the affordable zone. So I think with these comments, I thank all the speakers, panelists, and our international speaker and Merck team for bringing us together on this platform for sharing our thoughts. Thank you very much.
Thank you so much, sir, for beautifully summarizing and sharing your perspective. With that, we can conclude the session for today. Thank you, everyone, for joining, and also our live audience listening to the session. Have a good evening. Thank you.